Hi, my name is Andrea Moya, and I chose acuity-based staffing for my project. My current nursing practice setting is in a critical illness recovery hospital. It is a 40-bed hospital where we take care of patients with trachs, on ventilators, critical drips, patients with wound care, or medically complex patients. At our hospital, we use acuity-based staffing. Acuity-based staffing regulates the number of nurses on a shift according to the patient's needs and not according to the raw patient numbers. So not certain ratios like one nurse for 3 patients. So acuity is a measurement of the intensity of nursing care that is required by a patient. I chose acuity-based staffing because I am a house supervisor or charge nurse for my facility, and when I came on, I was never trained on how to properly do the acuity-based staffing. I would always staff my nurses based on what the nurse last night staffed their nurses on. So whatever they gave me, I would give them, but then we would run into issues on staffing, and I didn't really know what to do as far as acuity. So my goal for this project was to educate myself, to be able to communicate with staff members to find out acuities, to keep our patients safe, and to be able to support my nurses. In my current nursing practice facility, they staff by acuity. Their acuity ranges from level 1 to level 4. The sicker the patient and the more critical they are gives them a higher acuity. Most patients in the facility are level 3 to level 4, depending on if they are on critical drips, if we're titrating those drips, their oxygen needs, and what's going on hemodynamically with the patient. We also have patients that are there for wound care and IV antibiotics who usually qualify for level 2s. There are exceptions. If you have a patient who has an ET tube, you automatically qualify for a 3-to-1 staffing level, as well as if you have a patient who just had a trach surgically placed within the last 72 hours. Most of the literature I have found while researching my topic aligns with my nursing practice. For example, most of the literature has found to have a workload goal of 8 to 10. At my facility, our goal is 8 to 10 and never more than 12 of an acuity for any nurse at one time. In doing this, when we assess our patients and really do a good assessment, we're able to find out the work skill, experience, capacity, and needed of those nurses. And while we're looking into that, we are able to equally distribute that workload throughout the patients, making sure that the nurse isn't overloaded. We also have certain things that we look at in assessments such as medications, procedures, education, psychosocial, and complexity of the medications being given. As far as best practices goes, acuity-based staffing is not only great for patients, but it's great for nurses. As far as nurses, it's shown a reduce in nurse fatigue, nurse burnout, and improvement of retention and job satisfaction. Also for the patients, it has shown a decrease in mortality, length of stay, and adverse outcomes such as falls, infections, and pressure ulcers. As far as changes to my current facility's acuity-based staffing that I would like to see would be to revise the acuity tool yearly. Currently, the acuity tool has not been revised since 2018. I know that in nursing in the facility, we have changes every day. There's always something new coming out, always something new that we're learning about our patients and the health field in general. So I feel like that acuity-based staffing tool should be revised and should be changing with our patients and the way we take care of our patients. I also feel like we should be adjusting our acuity tool to our patient demographic and what goes on in our specific facilities. For example, we have been taking a lot of bariatric patients within the last couple of years, as far as like 500 and 600 pound patients, and we all know that those patients take 4 to 5 people sometimes to turn, to give baths, to give wound care, and that takes up a lot of time, and that is not something that's currently in the acuity tool for this facility. So I feel like we should always be just checking that tool and kind of making sure that it goes along with what's going on with our facility. The coronavirus has taken a major toll on healthcare. As far as my facility and staffing goes, it has not had any changes. Having coronavirus does not change anything for Acuity, unfortunately. If they're on the ventilator or on critical drips, it bumps them up there in Acuity, but just having coronavirus does not change anything Acuity-wise. I don't agree with this because I know that when you have to put on all the proper PPE, when you take off all your PPE, everything takes time. We have to decontaminate everything. We have to really make sure that everything's done properly so that we're not spreading anything and that we're being safe and keeping ourselves and our patients and our families safe. I know that takes longer, and I feel like that should be something that is implemented in this tool. However, it is not. As far as everything else goes, everything's been a real roller coaster. I know every hospital is probably like this. When we first started, we were told that we weren't going to take any coronavirus patients. Then we were told that we will be taking coronavirus patients who are in recovery who have had 2 negatives, so they weren't in isolation. Then we were told that we were taking coronavirus patients. They were in recovery but hadn't had any negatives, so they were in isolation. So it's just been a real roller coaster. Also with PPE and masks, that's been kind of crazy too. We were able to wear our own masks, then we had to wear the ones the hospital gave us, and then we weren't able to take them home. They had to stay in the building. So now we have bags and masks lined up by our front door. So when we come in, we get our temperatures taken, we get our masks, we have them for 3 shifts before we can get a new mask. Another thing that I never really thought of when this happened was thermometer shortages. That was something that kind of took me by surprise. So we had a shortage on thermometers, and I just prayed every day that when you go to work that none of the nurses lost a thermometer and you didn't have to go to your director and say, hey, we need a thermometer, because they were so strict. Why? Did you look everywhere? And it was just something that I wasn't really expecting or thinking of. We also have kind of gotten not the best PPE. We've had some small gowns and just things we're not used to. But as far as PPE goes, we've always had all the supplies we've needed. We haven't ever been without or been unsafe. And then a new thing that happened was testing. So we have had a total of 3 staff members have coronavirus. The first one happened, and then our second one happened because we tested our people who had been around the first person. They had been tested and found positive, and then tested again, which was negative. So she was negative, and then a couple weeks later we had another staff member get coronavirus from her husband. So anything that is more than 2 positive cases is considered an outbreak. So the whole facility had to get tested. That was an experience. A lot of the people were surprised. They didn't really want to get it. Did they have to get it? It was obviously very uncomfortable, but luckily everything has came back negative so far that we sent off. I know this has been a learning curve for everybody, especially the family members. So when it first started, we had family members not be able to come into the building at all. Recently, we've been allowing patients' family members to come into the facility from visiting hours of 2 p.m. to 6 p.m. There is 1 person allowed to come to the facility. They are to check in, they take their temperatures, ask them all the questions, they watch them wash their hands, and they walk them down to the rooms. There are tape marks on the floor, and that's as close to the patient as they can get. They have to have their mask on that we supply them, and they cannot go any closer than 6 feet to the patient, which is really hard for patients' family members to be there and not to be able to touch their loved one or to be close to their loved one. And then as well, the doors must remain open, and they have to wear masks that we provide them that don't leave the building. So they are good for 1 week. So only 1 person can visit per week, and then another person can come for a week. It's not 1 person one day, another person another day. So then that has a hard effect as well on family members who are wanting to see and I know that puts stress on them because you don't want to say that your mom can't see the patient, but you want to see them. So it's very hard. We're lucky because we are one level hospital, so our family members are able to go to the windows of the patient's rooms. We have a map on our front door that shows you how to get to your family members and loved ones' room. That way you can see them through the windows, you can call them on the phone, you can have that conversation to still see your family member and to know that they're okay. It gives some sort of relief feeling to the family members. I know it's been hard for everybody, and family members, patients, nurses, staff, hospitals, but it's something that we're going through and we're taking one step at a time, and we're just going to continue doing the best we can at what we're doing. And that's all that I have on my project, and thank you for listening.